Hello friends, welcome back to our second part of INICET recall sessions. A chronic smoker started recently working in a building factory. So his lung volumes have been given. His FeV1 was 0.9 liters and FVC was 1.9 liters. And he was given a bronchodilator, post which his lung volumes like FeV1 increased to 1.9 liters and FVC increased to 3.9 liters. And his FeV1 by FVC before bronchodilator was 0.4%. So this is suggestive of, they have asked A, is it having some vascular disease with bronchodilator reversibility, or is it restrictive lung disease with or without bronchodilator reversibility, or is it obstructive lung disease with bronchodilator reversibility? So let's see this question. Here if you see, let's take the reference of GINA latest guidelines. What it tells is, see, for the diagnosis of bronchial asthma, what we need is, first is the history suggestive of asthma, meaning the history must be variable. Okay, patient might have wheeze, cough, or any shortness of breath, which would vary seasonally, over time, diurnal variation, some variation suggestive of bronchial asthma. And the patient's spirometry should, if it has decreased FeV1, then FeV1 by FVC must be less than 0.8. Okay, actually 0.75 to 0.8 is normal, so it should be less than that. Plus it should demonstrate a variability. This is the characteristic feature of asthma. Variability will be there, meaning after bronchodilator their FeV1 will increase by 12% or 200 ml it will increase post bronchodilator. Okay, if it increases by 500 ml, we can tell with greater confidence that it is bronchial asthma. Or if there is any diurnal variation of PEFR showing variability more than 10%, or after treatment, 4 weeks of treatment, the same FeV1 increases by 12% or by 200 ml, or any exercise challenge test. All this challenge test they will be giving, methacholine challenge test. So any one of the component, if it is positive, along with FeV1 by FVC less than 0.75 to 0.8, then we come to a diagnosis of bronchial asthma. So here in this question, if you see, FeV1 by FVC was less than 0.75 to 0.8. So that means there is obstructive lung disease. Plus FeV1 has increased to 1 liter, meaning more than 200 ml it has increased. And if it is more than 500 ml, we can tell with greater confidence that it is bronchodilator reversibility is there and there is obstruction. So answer is option D, obstructive lung disease with bronchodilator reversibility. Combination of methylated cytosine yields. The answer is thymine. Okay, so actually when you see cytosine, when it is methylated and when the amino group is removed and that oxygen is added, then it gives thymine. Okay, answer is thymine. Next, false statement among the following is, prophylaxis for MAC starts at CD4 less than 50. Prophylaxis for cryptococcosis starts at CD4 less than 200. Prophylaxis for PCP starts at CD4 less than 150. And prophylaxis for PCP is stopped if CD4 is more than 350 at 0 as well as 6 months apart. So what is a false statement? So let's see in detail about CD4 count and HIV, what and all we should be remembering. So CD4 count and opportunistic infection. This is the picture given in NACO 2022. So here if you see, when the CD4 reduces to less than 350 itself, there is a risk of pneumococcal PCP infection, pneumocystis pneumonia infections. And less than 200 if you see, the risk of cryptococcosis infection starts, and less than 50 there is very high risk for MAC infections. Okay, so here How to give cotrimoxazole prophylaxis for PCP. See, whenever the CD4 count becomes less than 350, you must start the patient on cotrimoxazole. If the patient is allergic to cotrimoxazole, desensitize him with cotrimoxazole, start him on cotrimoxazole. There is no other alternative. Okay. So after starting, you should be monitoring your CD4 count. If the CD4 count remains more than 350, and it must be on 2 occasions at 0 as well as 6 months apart, then only you can think of stopping this cotrimoxazole prophylaxis. And next is CD4 less than 200. We told cryptococcosis. So here you should examine the patient for signs of meningitis is there or not. If it is not there, obviously serum cryptococcal antigen should be tested. Okay, this is as per latest guideline. If it is negative, no need of any prophylaxis. If it is positive, you must do lumbar puncture for this patient. And if the CSF cryptococcal antigen comes out to be positive, then that means the patient is having active cryptococcosis. So you must start treatment of cryptococcosis like induction with flucytosine as well as amphotericin B and maintenance with oral azoles. Or if CSF cryptococcal antigen is negative but serum antigen is positive, here comes the role of preemptive fluconazole prophylaxis. Okay, here prophylaxis, fluconazole therapy is needed. Next, at CD4, any CD4 count, what about TB? The recent guidelines tells that in a patient of HIV, test for tuberculosis, pulmonary tuberculosis, sputum CBNAT must be done. And Montu test must be done. Okay, if it is found to be positive, then the patient must be started on category 1 ATT, anti-tubercular therapy initially. After some time, you will be starting ART, antiretroviral therapy. Okay, next, if this test found out to be negative, then also you must give TB preventive therapy. This is as per recent guidelines 2021. Okay, you should be giving isoniazid as well as rifampicin prophylaxis, that is just weekly 1 tablet each for 12 weeks. That's all. Previously they were giving 6 months of daily isoniazid. Now it is replaced by isoniazid and rifampicin weekly just for 12 weeks. That's all. It's must to be given in all HIV positive patients testing negative for tuberculosis. Okay, so obviously the answer becomes prophylaxis of PCP. It's not started at CD4 less than 150, less than 350 itself it is started. Yes. Next question, foramen bounded by 3 bones. The answer to this is foramen lacerum. If you see this lacerated foramen, actually in the bottom there will be no foramen. In the top there will be a foramen in the middle cranial fossa. So actually what happens is the internal carotid artery will be traversing through the carotid canal and it will be going and it will be entering the foramen lacerum. Anteriorly if you see, you can see the sphenoid bone, and posteriorly if you see, you can see the petrous apex of temporal bone. And in this, the other picture, you can see the occipital part of the bone also forming a segment of this foramen. So 3 bones, temporal bone, occipital bone as well as your sphenoid bone. All these forms this foramen lacerum. Structure has been marked in this picture and they're telling this structure supplies what of the following muscle? A. Lateral rectus, B. Risorius, C. Medial pterygoid. So if you see, they are marked the facial colliculus. As we know, facial colliculus is the bulge produced due to from the abducens nucleus, 6th cranial nerve emerges and it surpasses the 7th nerve nucleus and forms the bulge. Okay, that is called facial colliculus. So this 6th nerve supplies nothing but our lateral rectus, LR6. Okay. Next, in a chronic alcoholic patient has been given and the patient has been binge drinking alcohol and suddenly stopped drinking alcohol. So now for this patient has started to develop alcohol withdrawal features and his LFTs are markedly deranged, GGT is elevated, AST, ALTs are markedly elevated. So for this patient, how are you going to manage? Chlordiazepam, or clonazepam or lorazepam or alprazolam? What are you going to give? So if you see the benzodiazepines, actually, how do they get metabolized? If you know this, you can decode what is happening. How it is cut by our body, metabolize. If you see in the liver, two phases of metabolism happens to detoxify this benzodiazepine and deactivate this drug. Phase 1 by CYP3A4 enzymes and phase 2 by glucuronidation. So by two steps it is happening. So this class is the longest acting and the drugs in this class is chlordiazepoxide and diazepam. So since it is longest acting, it will be stimulating the GABA receptors for a long time. So the patient, this is used for treatment of alcohol withdrawal. It will be prolongedly, it will be stimulating the GABA receptor. But at the expense of getting you metabolized by liver in hepatic injury conditions, you can't give these drugs. So next group of drugs, if you see, they don't have any CYP3A4 metabolism. They only have glucuronidation step alone. So little bit workload for the liver. This group consists of lorazepam, oxazepam as well as temazepam. Since it is having decreased workload, they can be preferred in alcohol withdrawal. And third group is the shortest acting group having fastest glucuronidation step alone, comprising your zolams, alprazolam, midazolam. So since it is this fast acting, it will act and it will go off. So this itself will produce withdrawal. So in a patient having withdrawal, you can't give zolam group of drugs. And you can't give chlordiazepoxide and diazepam because patient is already hepatic injuries going in this patient. So best drug in this condition is lorazepam. Lorazepam is always preferred in these alcohol withdrawal conditions having acute hepatitis happening on. Okay, yes. Next, most common form of pot spine is nothing but, as we know, it's nothing but paradiscal. It's not anterior posterior, it's paradiscal form. Okay, next, in a normal healthy adult, the ratio of T cell is to B cell is, it's nothing but 1:1, 2:1, 3:1 or 1:2. Answer nothing but 3:1. Actually T cells are more. Okay, you can remember like T cells has TH1, TH2, TH17 cytotoxic T cells. So you can remember like 3:1, 4:1 ratio with B cells. Triad in angle closure glaucoma, they have just asked the name of the triad. It's nothing but Oakes triad. Next, HPV. Lethal strains of HPV causes all of the following except lethal strains means those which have the ability to cause cancer. Mostly they inhibit this P53 gene and cause cancer. So this E6, E7 proteins and all. So most the HPV 16 and 18 have this potential. They are seen in oral carcinomas, anorectal carcinomas, invasive cervical cancers. Okay, but laryngeal papillomatosis, if you see, mostly caused by 6 and 11. It can also be caused by 16 and 18, but still most commonly, if you see, 6 and 11 only causes laryngeal papillomatosis. So the option here will be laryngeal papillomatosis. Next, a picture of this is given, a vesicular eruption which is found in the chest for 2 days, which is nothing but herpes zoster. In a dermatomal segment vesicular eruption, nothing but herpes zoster. It usually gets reactivated in times of immunosuppressed individuals or in times of any stress, fever, infections. In that time, this zoster virus can reactivate and produce vesicles over that area. Next question, a pregnant female who just got delivered has massive postpartum hemorrhage, following which the patient was having palpitations, dizziness and hypotension refractory to IV fluids. I don't know the question statement exactly. And BP was found to be 60/40 and pulse rate was found to be 140. So in this patient, what will you prefer to give? A, the L-troxin or thyroxine, B, glucocorticoids, or C, growth hormone. So here if you see, it's nothing but postpartum ischemic necrosis of the anterior pituitary is happening. Nothing but Sheehan syndrome. So in Sheehan syndrome, anterior pituitary is getting necrosed due to hypotension caused by this massive PPH. So if one by one hormones are start to decrease, like TSH decreases causing hypothyroidism, and ACTH decreases causing hypoadrenalism. Growth hormone can be decreased. FSH-LH decreases causing hypogonadism. So here, what will you prefer treating first? Obviously, first you should focus always in giving glucocorticoids or hydrocortisone. Then you can correct the thyroid problem. Like thyroxine supplements can be given after glucocorticoids. Because if you give L-troxin or thyroxine initially, thyroxine, as we know, it increases the basal metabolic rate. Okay, so it is nothing but it is like inducing a stress response to the body. So for fighting the stress response, you need cortisol. Already in Sheehan syndrome, there is hypoadrenalism, hypocortisolism. So it will further aggravate the hypocortisolism, and mortality will be increased like anything. So only, obviously, first answer should be glucocorticoids, next followed by L-troxin, thyroxine supplements. Okay, yes. Next, picture of this flower was given, and they were asked to find it's nothing but Argemone mexicana. Next, in rheumatoid arthritis, not the first line management drug: azathioprine, methotrexate, sulfasalazine, hydroxychloroquine. Obviously, answer is azathioprine. In rheumatoid arthritis, we usually start with monotherapy like methotrexate. Then we add sulfasalazine as well as hydroxychloroquine. And we add glucocorticoids only during the induction phase, like 3 months. After, and we also have levamisole as a reserve drug. And after starting, we see the response. If there is indication for biologicals is there, we can also consider early introduction of biologicals too. Okay, but definitely azathioprine is not in this list itself. Okay. Next, direct pathway. So for this, we'll see what is actually happening. If activation of direct pathway, what does it do? So here, this is the cross-sectional section of the brain. So if you see here, first, the substantia nigra, dopaminergic neurons from the substantia nigra stimulates the putaminal nucleus. So putamen means striatum. So from the striatum, fibers go to the globus pallidus interna, but they gave pallidum as in the options. From globus pallidus interna, inhibitory fibers go to the thalamus, and from thalamus, stimulatory fibers goes to the cortex. This is the normal direct pathway. So if I want to do a movement, what happens? Impulses come from the cortex, planned movements from premotor as well as supplementary motor cortex, as well as from the dopaminergic neurons from the substantia nigra, stimulate the putaminergic inhibitory neurons. These neurons, when it's stimulated, lot of inhibition is poured over the inhibitory neurons in globus pallidus interna. So now this inhibitory neurons in the globus pallidus interna won't fire at all. So now thalamus, stimulatory fibers in the thalamus becomes excessively active and fire the cortex and stimulate that part of the motor cortex responsible for a particular movement. Agonists are stimulated. So the stimulation of direct pathway produces stimulation of agonist and thus movement. So this is the order: substantia nigra, striatum, pallidum, thalamus to cortex. Okay, yes. Next, yes, true statement regarding clear cell carcinoma of kidney are: A, most common sporadic renal cell tumor, and B, a third chromosome long arm is affected, and C, arises from distal convoluted tubule. D, histology shows glycogen as well as lipids. So here if you see, the third chromosome, short arm, 3P contains this gene VHL. What does it produces? It produces a ligase. What does it do is, in our body there is continuous production, some minimal hypoxia will be produced here and there. So for this hypoxia, body reacts by producing hypoxia inducible factors. So these factors are these factors should be destroyed if there is no significant hypoxia. Okay, so to destroy this ligase, what it does is it captures all the HIF and puts into this grinder and crushes it off. Ubiquitin is the grinder which will grind and crush this HIF. So here this 3P gene, either if it is deleted at all, then it causes sporadic renal cell carcinoma. If it is mutated by gene silencing methylation, then it causes hereditary renal cell carcinoma. So now let's come to the story. So what was happening? This 3P was not functioning. No ligase is produced now. So whatever minimal hypoxia is there in the body, now lots of hypoxia inducible factors will be produced. And these factors, there is no inhibition for them. They will go and stimulate angiogenesis. Body thinking hypoxia, it will produce lots of angiogenesis. Angiogenic factors like VEGF, PDGF. It will cause sprouting of new leaky capillaries from the existing blood vessels. So only we see lot of hemangioblastomas in this disorder. Okay, hemangioblastomas seen in the retina, seen in the cerebellum, as well as in the kidney. It is called clear cell carcinoma. So whenever in a tissue, most hardworking cell in kidney is nothing but our proximal convoluted tubule. This can undergo hypoxia so easily because they are so much hardworking. Slight hypoxia is so common. So what happens here? Even if slight hypoxia happens, this HIF is produced in excess, and excess of neovascularization happens, and lot of capillaries sprout here and there in near the PCT, and PCT cells, due to excess blood flow, excess energy, all the glucose is converted to glycogen and all the fatty acids are converted to lipids, and they are stored within the cells. So now just visualize what's happening. Our histopathological picture will be going to look like columnar epithelial cells which are filled with PAS positive or pink color shade of glycogen, and clear cells because lipids won't stain the H&E stain. So it will be clear cells and also lots of blood vessels. So reddish capillaries will be sprouting here and there. So just visualize this picture here in front of you. You can feel the neovascularized blood vessels, clear cells, and glycogen stored vacuoles. And gross anatomy picture also, if you see, there is lots of lipid deposition, yellowish deposition, and leaky vessels are there obviously, so it will rupture and it will bleed, and necrosis can also be seen. This is clear cell carcinoma kidney gross picture. So obviously the true statements are, it is a most common sporadic cell tumor. 3P is affected. It's a short arm, it's not the long arm. So it's a false statement. And it arises from PCT, proximal convoluted tubule, not DCT. And option 4, histology shows glycogen as well as fat. It is true. So A and D, the option which said A and D is true, is the correct answer. Okay. Thanks for watching. If you have any doubts, you can comment in the comment section, or if you have any recollected question which you are feeling doubtful, you can comment in our comment section. Thank you.